All right, thank you very much. My first question is really a Slido question, and I just kind of want to get everybody's sense before I start talking about this. Who feels like damage control laparotomy, specifically in trauma, I'm talking about trauma mostly in this talk, do you think it's increased, decreased, or stayed the same over the last couple of years? Yeah, so it has decreased. So when I was training, which is longer ago than I look, damage control laparotomy was actually a relatively new thing, and everybody got all excited when there was one in the ICU. And then we went way overboard the other way, and we're doing way too many damage control laparotomies that didn't need to be done. And now we're sort of going back to what I think is probably a happier medium with regards to damage control laparotomy. So in your practice, do you use damage control laparotomy more for resuscitation and patient stabilization, for acute care general surgery, or for traumatic injuries and packing? Yeah, and I sort of thought in this group that would be way more common, that we would use it for acute care general surgery, and that's probably more what I use it for as well. But for the purpose of this talk, we're going to talk about trauma specifically, the damage control laparotomy in the setting of trauma. So for this talk, I'm going to use a case as an example, and as we go through the case, we'll talk about the decision-making that we make in each different area and why. So this is a 19-year-old male who comes to your hospital, whether or not it's a trauma center, with a gunshot wound to the abdomen. You have to take him emergently to the operating room because he's unstable. And when you get there, you find that he has a liver injury, a retroperitoneal hematoma, a pancreatic injury, and a through-and-through injury to the transverse colon. And as you start the laparotomy, he becomes very hypotensive. He has a pH of 7.1, and anesthesia has given 2 units of blood and 6 liters of crystalloid. So as I sit there as the surgeon taking care of this patient, I am definitely doing a damage control laparotomy on this patient. And the judgment for me here is basically 3 things that I see as I present this case that say this patient just needs damage control. The first thing is the significance of his injuries. He's got a lot of significant traumatic injuries that are going to require quite a bit of work to fix and quite a bit of time to fix, and maybe in some cases a specialist to fix depending on your own comfort level. So that lends itself to a damage control laparotomy. The second thing is he's starting to head for the triad of death, which, as we all remember from our residency training, is cold, coagulopathic, and acidotic. And once you start to hit acidotic and hypotensive, I need to get out of that operating room super fast. This guy's getting a damage control laparotomy. And then the third thing that screams to me that this guy needs a damage control laparotomy is his resuscitation has been very poor. So 6 liters of crystalloid in a trauma patient is bad news bears. We should have been giving way more blood and FFP and cryo and platelets and everything else to this gentleman and not crystalloid. So because of those things, this is a guy that's going to get a damage control laparotomy. And, I work at a level 2 trauma center in a city, but I also am part of a system. And when I get patients transferred to me from smaller hospitals in the system that aren't trauma centers, I sort of have come to find out that a lot of smaller non-trauma centers don't have the same resources that I would expect them to have. For example, there's a pretty good hospital about 20 minutes away from mine that has 2 units of blood in their blood bank. So there's no way that guy is going to get a balanced resuscitation if he shows up in their ER. But they are going to have to operate on him first before they send him to me because he's going to exsanguinate and die if they try to just send him. So if you're at a facility where FFP is going to take 2 hours to thaw, or maybe you've got to call the Red Cross to get it first or whatever, you're definitely leaning more towards a damage control laparotomy in that setting. So what is it? What are we talking about here? We're basically talking about controlling bleeding and gross contamination, and that's it. We're not fixing anything. We're just stopping the bleeding, and we're controlling contamination. And the goal is to get out of the OR, restore the patient's physiologic status, and then come back and do definitive repairs of things when the patient's in a better place. The problem is, of course, that although it's life-saving, there's really some significant morbidity associated with this. All of you have seen the significant and horrific hernias that can come from doing a damage control laparotomy. We had whole bunches of talks yesterday, and probably a lot of those TARs may have come from a damage control laparotomy at some point. Enterocutaneous fistulas are a big deal, but these are if the patient lives. In the immediate postoperative period, you're talking about significant fluid shifts in somebody with an open abdomen that were already having trouble resuscitating. And so leaving an abdomen open is not without morbidity and concern. So when I am trying to make the decision in the operating room if I'm going to leave somebody open or if I'm going to actually try to fix them, it really comes down to two things for me. The severity of the trauma. How bad is it? How much is going on in there? And how is the patient handling it? And where those two intersect is where I'm going to be doing a damage control laparotomy. So you can have a young person who has horrible injuries but is doing just fine. That person probably doesn't need a damage control laparotomy. And you can have other patients that are doing absolutely horrifically from a physiologic standpoint, but that may be because they have bad CHF or you've just pushed them over their Starling curve or whatever else, and their trauma injuries aren't that bad. They probably don't need damage control laparotomy either. But it's where the two meet that we're talking about doing a damage control laparotomy. And so from a patient selection standpoint, the key thing that we're trying to avoid is the triad of death. And we're trying to get this patient out of the operating room before they start spiraling with that coagulopathy that you simply cannot reverse no matter how hard you try. So when you start to recognize that this may be the patient that's going to head for that lethal triad, that's the moment that we're doing the damage control laparotomy. Some of the more sophisticated trauma centers have TAG. They have other ways of looking for that coagulopathy. If you're not at a level 1 trauma center, you probably don't have access to that. So it's a little bit more of a guessing game in terms of how close you are to really reaching that coagulopathy. But you want to try and guess and see if you can get there before they end up in the triad of death. The other thing that I think is really important is that we talked a lot yesterday, or at least the great hernia folks talked a lot about yesterday, how you don't get compartment syndrome after you do a TAR, the abdominal wall is so elastic, everything's great, don't worry about it. This is a different patient population. You definitely can get a compartment syndrome in these patients, and you definitely can get it from too much crystalloid. So we really have to be on top of the patients that have gotten a lot of crystalloid and consider the fact that they may just need a damage control laparotomy. If you're in there and you realize this guy's going to need a couple of operations, this patient needs a specialist that I don't have here in the middle of the night, maybe he can come in tomorrow, maybe I need to send it to the level 1 center, you definitely are thinking that you're going to have to do at least 1 or 2 second looks. If you have to pack somebody and then you're hoping to send them to IR, or you've put up a Reboa, and maybe they're going to have to go to IR and you're going to try to leave the Reboa in for a little bit, these are all people that are going to end up with a damage control laparotomy. So once we get into the operating room, what are we doing? Well, first of all, we're stopping bleeding. Bleeding is what will kill you first. That's what we're doing. And when you make the decision to do a damage control laparotomy, you're no longer talking about splenic salvage and, well, maybe if I just suture this kidney, it'll stop bleeding. Like, you're really talking about, I need to be in and out of this OR within 60 minutes. What do I do to stop the bleeding and get them out of the operating room? So these patients are getting splenectomies. They're getting nephrectomies if you need to do that. You're going to use cauterization, and I talk about it more in my liver talk, but most standards bovies go up to 120 on the cautery, which is not quite as much as an argon beam, but it's pretty darn close. You can cauterize an awful lot with 120 on your bovie. Dr. Inaba next is going to talk about shunting, so I won't go into it in too much detail, but shunting is a great option in this case. And then you're going to pack, particularly the liver, but any other place that you need to, just to try and get control of bleeding and get out of the operating room. Once you've controlled the bleeding, then your second step is to control any gross contamination. Things like the pancreas are probably going to just get drains in a damage control setting as opposed to doing like a distal pancreatectomy or, God forbid, a Whipple. We're not going to do that in a damage control situation. And then as far as the bowel is concerned, you're stapling off and that's it. No anastomoses, nothing else. You're just stapling off. All right, so our 19-year-old gunshot wound patient, he is packed and he is resuscitated. We left some drains near the pancreas. We stapled off the colon. The liver seems to stop bleeding with packing. The retroperitoneum is no longer expanding, so we don't think he's bleeding from there. how do we close the abdomen on the first operation? So there's a bunch of different options. There appears to be, at least when you look at the more recent literature and Twitter chat, to primary skin closure only. And the favorability for this is because you limit the amount of fluid shifts from an open abdomen if you just close the skin. But the problem is, if you're not getting a good balanced resuscitation, or sometimes even if you've got a bunch of packs in there, whatever, there's no way you're getting the skin over this massive mound of bowel that's kind of sticking out of the abdomen. So this is where you're probably going to use some kind of closure device. There's some commercially available ones. There's wound vacs. I use a made-up kind of cheap version because, of course, in the middle of the night when this is happening, the OR nurses can't find the commercially available wound vac. But in any case, what you're doing is just getting the bowel covered with some kind of vacuum-assisted device for the most part, or a skin-only closure. And then you're going to take the patient back to the operating room, and the key here is ongoing resuscitation. You're going to warm them. You're going to continue with your good one-to-one-to-one resuscitation. You're going to correct coagulopathy aggressively. Now, depending on how long you're planning on waiting before you take the patient back to the operating room for their definitive operation, you can extubate somebody that has an open abdomen. I personally have never done it, but you certainly can do it. You can start them on early enteral feeds, and you should if that's at all possible. There aren't any specific indications for antibiotics, even if you have an open abdomen. But you do have to be aware, and this is a really important point, that you can get compartment syndrome with a wound vac or an open abdomen in place. I have gone up to the ICU more than once and ripped a wound vac off of somebody because they developed a compartment syndrome, particularly if they've gotten too much crystalloid, and the wound vac is not compliant. It's not like a TAR. It's not going to move with the abdominal wall, and you can actually get compartment syndrome. So don't be fooled into thinking that you're out of the woods with compartment syndrome just because there's a wound vac on that. So we finally take the patient back to the operating room on post-trauma day 3. At this point, he is off pressors. No further blood products have been required, and he's actually tolerated 1 dose of Lasix. The pancreatic drain output, however, is quite significant. He likely has a main duct injury. So when we go back in, we decide to actually definitively deal with the pancreas, and we do a distal pancreatectomy. The liver has stopped bleeding all on its own when you remove the packs, but the colon, what are we going to do with the colon? Are we going to do an anastomosis? Are we going to put things back together and divert with an ileostomy? Are we just going to do an end? And the data would say that you can do a lot of these different things, and it kind of depends on what your comfort level is. In my practice with these patients, they've already taken a major hit, and I feel like if they leak, that could be the end. So I am pretty aggressive with end colostomies. I know they're probably going to get a hernia, and I can take down their colostomy when I fix their hernia in a year. But there are other people that are more aggressive with putting people back together and doing diverting loops. And if they are truly hemodynamically stable and doing well, you can, in theory, do an anastomosis. Certainly with small bowel, we would do an anastomosis. Colon, definitely you're living on the edge a little bit more with that. So the complications of the damage control laparotomy. First of all, we all know enterocutaneous fistulas are definitely a problem. The longer you leave somebody open, the more likely you are to get an enterocutaneous fistula. We all try all kinds of different things. Well, we'll turn the wound vac down from 125 to 75. Well, what if you use white foam? Well, what if we try? There's still a pretty high risk, and the sooner you can get the patient closed, the better. Intra-abdominal abscesses certainly can occur. They get rip-roaring ileuses, particularly if they've gotten a lot of fluid, as I mentioned before. The loss of fluid and protein can make it difficult for you to resuscitate somebody. And then, of course, the loss of abdominal domain and ventral hernias are quite significant and keep my partners down at main campus in practice. So when you go back for the second operation, how are we going to definitively close the abdomen? Ideally, we all just want to do a straight-up fascial closure. But in this patient population, I really do pay attention to the plateau pressures. It is really important here because if you pull them too tight, they do not have the abdominal walls like the TAR patients do that are very lax. And you can get a compartment syndrome when you try to pull them closed too tight. So as my plateau pressures go up, if I can't get them all the way closed, I usually use Vicryl mesh. I find it to be the cheapest alternative, and I know they're going to get a hernia at that point, but you can use any of